Today, I'll walk you through the key updates in the 2026 Second Universal Definition of Heart Failure, published jointly by the AHA, ACC, ESC, and World Heart Federation. I will highlight the high yield points for your clinical practice or training. This document builds on the 2021 First Universal Definition and introduces important changes to how we classify, stage, and think about heart failure. Several factors drove the need for this updated consensus. Heart failure prevalence is rising globally, fueled largely by HFpEF, an aging population, and increasing comorbidities. Advanced imaging and AI-based ECG tools are identifying disease earlier. Routine genetic screening is now more accessible and affordable, expanding our understanding of heritable cardiomyopathies. Definitions of heart failure used in clinical trials vary widely, often restricting eligibility by narrow LVEF ranges and obscuring benefits of therapies across the EF spectrum. Importantly, this is a definition document, not a guideline. It does not make specific treatment recommendations. The core definition of heart failure has not fundamentally changed. It remains a clinical syndrome diagnosed through a combination of symptoms, signs, biomarkers, and imaging. No single test confirms or excludes the diagnosis. This is particularly relevant for HFpEF, where natriuretic peptides can be normal despite clear invasive evidence of elevated filling pressures. Let me step aside so you can see everything that I put here. Table 1 of the Universal Definition reaffirms the AHA-ACC heart failure staging system, stages A through D, from the first Universal Definition. Stage A, which is at risk, refers to individuals with risk factors such as hypertension, atherosclerotic cardiovascular disease, congenital heart disease, diabetes, obesity, cardiotoxin exposure, or family history of cardiomyopathy, but no current symptoms, structural changes, or elevated biomarkers. Stage B, which is pre-heart failure, refers to individuals without symptoms but with evidence of structural abnormalities such as LV hypertrophy, chamber enlargement, wall motion abnormality, myocardial edema or scar on cardiac MRI, valvular disease, abnormal cardiac function such as reduced LV or RV systolic function, increased filling pressures, abnormal diastolic function, or elevated natriuretic peptides or troponins, especially in a setting of cardiotoxin exposure. Stage C, which is the heart failure that most people think about, are individuals with current or prior symptoms or signs of heart failure caused by a structural or functional cardiac abnormality. Stage D refers to advanced heart failure, severe symptoms at rest or minimal exertion, recurrent hospitalizations despite guideline-directed medical therapy, refractory or intolerant to GDMT, requiring advanced therapies such as inotropes, cardiac transplantation, mechanical circulatory support, or palliative care. The staging system emphasizes that progression from stage A to D is not necessarily unidirectional. Going back to an earlier stage is possible with GDMT and risk factor modification. The existing approach of using specific LVEF cutoff values to define heart failure phenotypes was challenged by known variability in echocardiographic LVEF measurements, difficulty interpreting LVEF across different imaging modalities, and ongoing debate about whether cutoffs should be adjusted for sex, age, and ethnicity. The lower limit of normal LVEF is approximately 53% in women and 52% in men, with slightly higher thresholds in individuals of Asian origin. And LVEF below 50% is unlikely to reflect normal function regardless of sex, age, or race or ethnicity. So they write, and I quote, "The second universal definition of heart failure therefore moves away from using specific LVEF cutoffs." They say that this allows clinicians to account for sex, age, and ethnic differences in LVEF thresholds on a case-by-case basis, rather than applying a rigid universal cutoff. However, I feel that we are left hanging a bit here. While removing the old LVEF percent cutoffs I was hoping that they would supply a nomogram by age or sex or some other definition to guide us, but they did not. This table illustrates the variability in how heart failure causes have been classified across three major existing frameworks. The ESC 2021 guidelines use broad pathogenic categories. The AHA-ACC HFSA 2022 guidelines use a more granular list. The significant variability in how causes are categorized across registries and clinical trials leads to inconsistencies in data collection and challenges generalizing trial results. This variability is the motivation for introducing a new universal classification of heart failure by cause. This is the new proposed universal classification, listing 16 pathogenic groups with specific clinical examples under each. The categories include ischemic, hypertensive, valvular, arrhythmia-related, infiltrative, including cardiac amyloidosis, hemochromatosis, and Fabry's disease, infective, including viral myocarditis, Chagas disease, HIV, and Lyme disease, inflammatory, including autoimmune and sarcoidosis, toxic, including medication-induced alcohol, cocaine, and amphetamine, heritable, including HCM, DCM, restrictive, arrhythmogenic, non-dilated LV cardiomyopathies, pericardial, metabolic nutritional, including obesity, diabetes, thyroid disease, thiamine and vitamin B1 deficiency, pregnancy-related, stress-induced, Takotsubo, pulmonary right-sided disease, congenital, high-output mediated, such as hemoglobinopathies and AV malformations, and idiopathic. Whether a patient has reduced or preserved EF, identifying the underlying cause should always be pursued because it directly influences treatment decisions. And as genetic testing becomes more routine, cases currently labeled as idiopathic will increasingly be reclassified into heritable categories. The spectrum of cardiovascular disease causing heart failure differs significantly between high-income countries and low to middle-income countries, and is further shaped by global migration patterns. Globally, ischemic heart disease accounts for the highest proportion of age-standardized heart failure prevalence in 2017, 26.5%, followed closely by hypertensive heart disease, 26.2%, and COPD at 23.4%. COPD is a leading contributor of heart failure in South Asia at 38.3% and East Asia at 34.3%. In Western high-income regions and Eastern and Central Europe, ischemic heart disease accounts for more than 50% of heart failure cases. In sub-Saharan Africa, ischemic heart disease contributes to fewer than 10% of heart failure cases. Hypertension, approximately 32 to 35%, and rheumatic heart disease are far more prominent in sub-Saharan Africa. In East Asia and sub-Saharan Africa, rheumatic heart disease accounts for 34% and 14% of cases, respectively. Alcoholic cardiomyopathy was a major cause of heart failure in Eastern Europe, 16.4% of age-standardized prevalence. Region-specific phenotypes include lean diabetic HFpEF in Southeast Asia, Chagas disease in Latin America, and hypertensive heart disease and peripartum cardiomyopathy in Africa. Unfortunately, the reality is sub-Saharan African participants are nearly absent from heart failure clinical trials, limiting the generalizability of current evidence to these populations. Figure 1 shows the most important conceptual advance in this definition document. The plot has a left-to-right timeline showing progression from stage A through stage D, with quality of life and exercise capacity declining as disease advances. Stage B patients do not yet have a permanent diagnosis of heart failure. Once symptomatic heart failure, stage C, is established, the diagnosis is considered permanent, even if they feel better or their EF normalizes. The key conceptual addition is that there are 3 rightward trajectories that can emerge from stage C symptomatic heart failure. Improvement imp heart failure, is when the LVEF improves with treatment, but structural or clinical abnormalities persist. Remission, REM, remission heart failure, is when LVEF normalizes with minimal symptoms and stable biomarkers, but vulnerability to relapse persists. We have to acknowledge that patients who had reduced EF and then improved are not the same as those who always had preserved function. They remain vulnerable and should not be taken off therapy simply because their echo looks better. That is not the same as recovery. Remission can lead to recovery, REC, heart failure, which refers to sustained normalization of cardiac structure, function, biomarkers, and symptoms over extended follow-up. Very few patients achieve true recovery. Bidirectional arrows between stage C and improvement and remission reflect the possibility of relapse. Patients with improved EF can revert to reduced EF if the therapy is withdrawn. Stage D, which is advanced heart failure, can emerge from stage C, and death is a possible outcome at any stage. This document provides important clarifications around worsening heart failure and decompensated heart failure, which are related but distinct concepts. Worsening heart failure is a trajectory event, a progressive deterioration in a patient who already has heart failure. It does not require a hospitalization to diagnose. Decompensated heart failure is a more specific and severe state, defined by the need for therapeutic escalation, most commonly during a hospitalization. Specifically, it tells us that worsening heart failure is defined by progressive deterioration in symptoms, signs, and quality of life in a patient with a prior heart failure diagnosis. Worsening heart failure requires a pre-existing heart failure diagnosis. New onset heart failure cases are excluded by definition. Clinical manifestations include worsening dyspnea, increasing peripheral edema, elevated biomarkers such as BNP, NT-BNP or troponins, malignant arrhythmias, reduced exercise capacity, and imaging evidence of elevated pulmonary pressures or worsening ventricular function. Worsening heart failure often prompts unplanned outpatient or emergency visits or hospital admissions, but these encounters are not required to make the diagnosis. On the other side, decompensated heart failure can occur at any point in the heart failure disease course, not only in the setting of worsening heart failure. Decompensated heart failure may present as a gradual deterioration over days to weeks, which is common in chronic heart failure, or as an acute episode such as pulmonary edema or cardiogenic shock. The hallmark of decompensated heart failure is treatment intensification, increased diuretic dose, initiation of combination diuretic therapy, or implementation of GDMT. More severe cases may require resynchronization therapy, valvular intervention, mechanical circulatory support, or transplant evaluation. Acute heart failure presentations are triggered by cardiovascular events, such as acute myocardial infarction, acute coronary syndrome, hypertensive emergency, arrhythmias, including tachycardiomyopathy, atrial fibrillation-induced cardiomyopathy, and PVC-induced cardiomyopathy, acute valvular disease, and pulmonary embolism, which can cause isolated right-sided heart failure. Non-cardiovascular acute diseases, including kidney injury, liver failure, and respiratory failure, can also precipitate acute heart failure through volume overload and neurohormonal mechanisms. Heart failure symptoms typically resolve once the primary cause is treated. Chronic or subacute heart failure presentations are common and often underdiagnosed. Symptoms develop gradually over weeks to months and may be subtle, increasing fatigue, mild exertional dyspnea, gradual weight gain from fluid retention, easily mistaken for deconditioning or normal aging by both patients and clinicians. Population data show that substantial numbers of primary care patients are treated with chronic diuretic therapy without a formal heart failure diagnosis. Natriuretic peptide screening can improve detection of chronic heart failure in primary care settings. So to conclude, the heart failure staging system A through D is reaffirmed in this definition document. Stage B, which is pre-heart failure, is a window for early intervention before symptom onset. HFrEF and HFpEF no longer have strict numerical percent cutoffs for EF. A universal classification of heart failure by 16 causes is introduced. 3 trajectories can emerge from stage C, which is symptomatic heart failure. Improvement, which is impHF failure. LVEF improves but structural or clinical abnormalities persist. Remission, which is when LVEF normalizes with minimal symptoms and stable biomarkers, but vulnerability to relapse persists. Therapy should not be stopped. Remission can lead to recovery, recHF, which is rare. Bidirectional arrows between stage C and improvement remission reflect the possibility of relapse. Patients with improved EF can revert to reduced EF therapy if therapy is withdrawn. Stage D, which is advanced heart failure, can emerge from stage C. Worsening heart failure and decompensated heart failure are distinguished as separate but related clinical entities. Okay, so we've covered a lot today. That's all for the 2026 Second Universal Definition of Heart Failure. You can read the primary document at the ACC, AHA, ESC, or WHF Guideline Hubs. Thank you for tuning in. Until next time.